Hello everyone, I am Surakshit Tiwari, a student from Medhavi Skills University, second year pursuing radiology. And today I'm here to talk about the topic radiation dose optimization in CT scanning. Before we get started, I have presented a small video in my laboratory, so I would like to uh, make you view the video first. So there was a small demonstration, an introduction to the topic we'll be discussing. So let's begin. Firstly, I would like to start with a little background. A CT scan delivers a relatively higher radiation dose compared to plain radiography. This raises concern about cumulative radiation exposure, especially in young patients or when multiple scans are needed over time. Radiation dose optimization means balancing the two opposite requirements: patient safety, minimizing radiation risk, and diagnostic quality, ensuring images are good enough for diagnosis. We accept that some radiation is necessary to perform images, but we must avoid unnecessary or excessive dose. Regulatory bodies and professional organizations emphasize two pillars in this regard: justification. No CT scan should be performed unless clinically justified. And optimization. Once justified, the scan must be done with an optimized protocol. The FDA also stresses that when imaging is done, patients should be exposed to an optimal radiation dose, no more or no less than what's necessary. In CT, dose metrics like CTD-IVO, volume CT dose index, and DLP are commonly used as practical indicators. Also, many countries adopt diagnostic reference levels, which represent a benchmark dose, often the 75th percentile of a distribution for standard procedures. If a dose exceeds DRLs, you should investigate and optimize. To demonstrate this further, for a clearer understanding, I would like to show you a short clip from a YouTube video that I find extremely helpful in explanation of this topic. Here we can see three images. Uh, One of them, the initial image on the left side, we can see it uses 30 milligray of radiation dosage. The central image uses 50 milligray of radiation dosage, and the right image uses 100 milligray of radiation dosage. You can see here, uh, in the 30 milligray image, the image is very grainy, very noisy, very distorted. We can we can see here that the image is extremely grainy or very noisy. Therefore, the image quality is very poor. In the center, we have an image which is significantly better as compared to the previous image because it is using more milligray or more radiation doses. And the image to the furthest is using 100 milligray, which is the most radiation dosage which is being used. We can see that the 50 milligray image and the 100 milligray image are almost identical. Like if you look at them at an instant, you can't even notice a difference. So here we can see And we demonstrate that there's a certain uh, fixated amount of radiation dosage needed to take, which ensures that no radiation dosage is being exceeded, which can be harmful to the patient, and it is delivering the optimal or the perfect image quality, which can be which is easily readable by the doctors or the radiographers. Here we can see the 100 milligray image can also be taken, but we radiographers we use 50 milligray instead of the 100, because if we use the 100 milligray uh, image, if we use 100 milligray to take the X-ray of the or the CT scan of the patient, they are being exposed to more radiation doses than they require. We simply lower down the milligray or the radiation dosage to 50 milligray, which gives just as good image quality, but uh, saves the patient from any risks or side effects. But if we use less radiation dosage, which is not harmful at all, which is 30 milligray, we are not going to get any image. We are not going to get an image which is easily readable by the radiographers. As explained here, optimal dosage, meaning that the 50 milligray image was optimal because it made sure the patient is not being exposed to more radiation than they require, and the image quality is being ensured that it is proper and readable by the radiograph. Okay, I will return to that later. We'll give our credits to Clover Learning for this very clear explanation about this topic. So let us continue. So the key parameters and trade-offs. To understand how to optimize those, we must understand what parameters influence it and how they trade off images quality, that is noise, contrast, and resolution. Here are the key CT parameters: tube potential or kV, tube current milliampere, pitch, rotation time, slice thickness, scan length, reconstruction algorithms, automatic exposure control. Okay, so some other factors or best practices for this topic are: use patient size adapted protocols, that is different parameters for small versus large patients. Use bow tie filters. Avoid unnecessary multi-phase scans. Be careful centering of the patient in the gantry. Periodic protocol review and audit. That covers the parameters slide. Next, let's see how this is put into practice. Workflow and implementation. Let us look at the topic. Knowing strategies is one thing. Implementing them reliably is another. We will now see that how to put those optimization into practice in a CT department. Here, I would like to show another highlighted area. Excuse me. Here, we can see CT diagnostic references levels for other CT applications. Because the practice of CT encompasses many more exam types than routine head and board exams, reference levels for many common CT examinations are important for continuing those optimization efforts in CT. To this end, several nation surveys have begun to assess a broader range of exam types. Additionally, the ACR has begun a project to automatically or collect CTD-IVOL data directly from the DICOM header, thus allowing considerably faster accumulation of data sufficient to establish reference levels for additional exam types. This information will extend the value of the diagnostic reference level concept to the majority of CT applications, enabling individual CT users and the community at large to answer the question, what doses are typical and what doses are too. So uh, let us look at some dose optimization methods or the practice we use in the CT department. Protocol review and standardization. Establish standard protocols for common examinations, that is head CT, chest CT, abdomen CT, etc., tied to acceptable image quality thresholds, as we have talked earlier. Use DRLs as benchmarks and adjust your protocols if your practice routinely exceeds them. Harmonize protocols across scanners if multiple CT machines exist in your facility. Form a CT dose and committee. Engage radiologists, technologists, medical physicists, and management. Monitor CT dose metrics, set targets, review outliners, feedback corrections. Education and training. Ensure technologists and nurses understand those principles and know how to choose or modify protocols. Clinical users, referring physicians also need to understand justification to avoid unnecessary scans. Routine dose, monitoring and audits. Collect data for each exam. Flag cases exceeding thresholds and review whether optimization is possible. Uh, Quality assurance and maintenance. Ensure CT scanner calibration is maintained. Verify that tube output, filtration, detector performance are within specifications. Periodic phantom studies to check images noise versus dose performances. Use of advanced tools, analytics. Some centers now use software to assist in protocol management, analytics of dose distributions, or even predictive models. AI-based reconstructions or advanced algorithms can further reduce requirement dose. Now we'll be talking about some challenges, pitfalls, and considerations every radiographer should take. Uh, while we aim for the dose optimization, there are real challenges and things to watch out for. Image quality compromise. Pushing those too low can lead to excessive noise or artifacts, making the image non-diagnostic. Scanner limitations. Older CT machines might lack sophisticated dose modulations or reconstruction methods. Variability in patient habitats. Large patients may need significantly higher dose to penetrate. Operator variability, protocol misuse. Technologists might inadvertently override optimized settings or use inappropriate protocol combinations. Institutional inertia, resistance to change, lack of leadership support, regulatory and reporting burdens. In some jurisdictions, those reporting and compliance adds overhead. Also, as Larson et al. Argue, we need to move target image quality based targets to setting for each protocol, and then aim to operate just above that. Continuous quality control is critical for maintaining optimization over time. So that is everything that I have demonstrated today. Thank you all for your time, and I hope to see you in the future. I would like to give credits to Abhijit sir for presenting me with this opportunity, and thank you.